Right. All right, so Kavita and the rest of the people, a good morning. Again, I'm happy to come back to speak to you about some of the issues associated with arrhythmia. Today's topic is sudden cardiac death associated with congenital heart disease. To the electrophysiologist, especially when it is associated with congenital heart diseases, because unlike the sudden cardiac death that is associated with ischemic heart disease, which is more common, the substrate in the congenital heart disease that leads up to the sudden cardiac death, it is presumed that the substrate is more definitive, easily recognizable, and hence amenable to therapy, which may even bring in the cure. So I'm very glad that I am speaking about sudden cardiac death issues associated with the congenital heart disease today. Let's talk about the definition. It seems to be a very simple definition. Sudden cardiac death could be defined as a death if it had occurred suddenly. That means within few hours of the onset of the symptoms, and that death needs to be natural, and it is either proved or presumed to be of cardiac origin. That's what is sudden cardiac death. I believe there is a lot of complexity behind the simplicity of the definition. If you go through the certificates of death or the notes wherein you would write the diagnosis of a death, there is no column where we need to be mentioning whether it is sudden or a gradual death. And hence, when we start collecting the data about the epidemiology of sudden cardiac death, most of the data is presumptive. If the evidence, the witness says that the death was sudden, we consider it is sudden, and then we look at the history or certain other autopsy findings, etc. And then if we think it is cardiac, we label that as sudden cardiac death. Similarly, in a hospital, the death certificates or death records, if you go across, we tend to presume that death could have been sudden if there was an episode of an arrhythmia, typically ventricular arrhythmia, during the hospitalization, or even in the past if there were to be a history of a ventricular arrhythmia. So, because we do not write, or there is no scope to write specifically whether it is sudden or a gradual, the data that is collected with respect to the suddenness of a cardiac death stands today very presumptive, and hence the data can be sometimes misleading. However, one thing is certain, the sudden cardiac deaths that could be attributed to congenital heart disease, their numbers, their epidemiology is evolving and it is increasing. And the attempts are being made to figure it out whether it is indeed a sudden cardiac death, because the data collection is also being refined. The seemingly increasing incidence of sudden cardiac death in congenital heart disease could also be attributed to the improved outcomes and the survival rates of the pediatric or the congenital heart disease patients. What is the available data regarding the incidence, the frequency of sudden cardiac death in patients with congenital heart disease? At the population of congenital heart disease below the age of 25 years, their incidence seems to be as much as those patients who are older and who are apparently normal, and that is about 1 per 1,000 patient years. That is in general. So this is telling you that the incidence may not be very high if you look at all the patients of congenital heart disease. let's look at are there any subsets where the incidence of sudden death is almost comparable with the high-risk patients of adults without the congenital heart disease. Two subgroups stand out. One is tetralogy of Fallot. Another one is where you have right ventricle as a systemic ventricle or a single ventricle pathology. The numbers are as significant as those patients in adults suffering from coronary artery disease. 20 to 50 patients per 1,000 patients years belonging to these two groups of congenital heart disease have the incidence. This is an interesting thing. The data collected among the adult population, the highest of the numbers of the sudden cardiac deaths occur in those patients with ejection fraction less than 30%, or those patients who have had a history of resuscitated cardiac arrest, or those patients who have the low ejection fraction for arrhythmia. Look at the numbers here. They are like almost 200 to 300,000 patient years. If you look at the last three categories, there are probably some patients with congenital heart diseases falling into this. So what does that mean? It is possible, even in congenital heart disease, to risk stratifying and figure it out who are those patients who are at risk for sudden cardiac death, even though it seems to be the contribution of congenital heart disease to the sudden cardiac death burden is small. There are subgroups who are at as much or higher risk of sudden cardiac death as compared to the adult population without congenital heart disease and still at risk for sudden cardiac death. There had been accumulation of data. For example, tetralogy of Fallot. For example, long-term follow-ups. Here I am putting as many as 5 large series, following up to from 20 years to 30 years. This particular data is probably undermining the exact incidence of sudden cardiac death. It appears that it's a benign course. Over a period of 30 years, if you follow the tetralogy of Fallot patients, the incidence seeming to be just about 1 to 2% per decade, which is actually smaller incidence than the normal adult population, which is really hard to believe. Similar very benign data also comes from the follow-up of patients who have had the so-called mustard and thinning procedures for TCAs, where it is the cardiomyopathy of systemic right ventricle is at play to bring in those malignant ventricular arrhythmias causing death. Let's look at it very quickly. I believe this is large data because there are as many as 7 series, 150 to almost 400 patients, and follow-up years, patient years is like 18,000. It's that per decade, the attrition rate due to the sudden cardiac death is about 5.6%, which seems to be almost 3 times more than the talk, but the clinical practice is different. So we have some different statistics regarding the follow-ups and the rates of sudden cardiac death. I attribute it to the way we define sudden cardiac death. Well, so if we leave apart that controversy associated with the incidence, let's look at the mechanisms which lead up to sudden cardiac death. There are 4 major groups of congenital heart disease who are predisposed to suffer sudden cardiac death. Tetralogy of Fallot, atrial switch causing the right ventricle as a systemic ventricle, single ventricle repairs, and residual left ventricular or the systemic ventricular outward tract obstruction. What is common feature among all these abnormalities is the longer duration of the follow-up. If you follow a patient for a longer time, however much there has been a correction of the underlying hemodynamics, still there is a residual stress and hence cardiomyopathy is seen. Longer the follow-up, greater is the incidence of sudden cardiac death in the patient. How about the symptoms? Simple palpitations or a malignant symptom like syncope may herald the event of sudden cardiac death. Similarly, at what age the patient underwent the repair determines the risk for sudden cardiac death. Older age, because at that time there could have been some irreversible hemodynamic changes which will persist and cause myopathy or fibrosis of the ventricles. Are there any hemodynamic issues which can help us to risk stratify? In TOF, many patients tend to have pulmonary insufficiency leading to RV enlargement. And if that RV enlargement associated with the systolic dysfunction, fibrosis also affecting the left ventricle, so one or more of these hemodynamic features may make TOF person suffer sudden cardiac death. Similarly, any residual defects leading up to the increased end diastolic pressure, increase in the chamber dimensions, which reflects either hypertrophy or fibrosis, they're all the substrates for ventricular arrhythmia. How about the specific electrophysiological features which may tell us these patients are at risk? One thing stands out. The so-called benign supraventricular arrhythmias are in no way to be looked at very casually if you are concerned about the occurrence of sudden cardiac death. Atrial tachycardia, as long as it is not causing fast ventricular rate, can be considered benign. But if the atrial tachycardia is associated with rapid ventricular rates, that can be a significant stress on the failing ventricles, and it may trigger malignant ventricular arrhythmia. So even in the older population of the congenital heart disease patients who seeming to be doing all right, if they develop a benign supraventricular tachycardia, seemingly benign supraventricular tachycardia may actually give rise to malignant arrhythmias. How about the non-sustained VTs and the PVCs? If you have a I'll come back to this a little later, but there are certain electrophysiological features. Number of PVCs, their burden assessed on Holter or otherwise. What happens in the EP study? What is the QRS duration? These all help in risk stratifying. In addition to some of the tachyarrhythmias, for example, atrial tachyarrhythmias, or for example in Epstein's anomaly, if there's an associated accessory pathway which is very common, can be a risk for sudden cardiac death. And then we discussed about the ventricular tachyarrhythmias. Even a patient with an VSD who is supposedly to be living almost a normal lifespan, developing atrial arrhythmias or a ventricular arrhythmias, he is also, and these arrhythmias not necessarily be leading to the syncope. These patients supposedly doing well, developing this kind of a seemingly benign arrhythmias should also be followed up more seriously. How about the bradyarrhythmias, which are very common in TGAs, especially after the repairs like mustard and sending and the Fontan repairs. The sinus node dysfunction is equivalent to the loss of AV synchrony. rise in the LVDP and triggering the ventricular arrhythmias. The AV blocks, the high degree AV blocks or the complete AV blocks, either the result of the surgical repair or the natural course, may tend to cause a long pauses, all right, which may cause sudden death, but the longer pauses may actually trigger ventricular arrhythmia. So an AV block per se may cause sudden death, but they can also trigger the ventricular arrhythmia. So in general, if you look at this table, none of the arrhythmias should be taken lightly if you are serious about sudden cardiac death. Among all the congenital heart disease leading up to a sudden cardiac death, tetralogy of Fallot has been studied extensively. Each one of the EP centers across the country at least now has at least 8 to 10 such cases of monomorphic ventricular tachycardia associated with TOF repair having undergone an ablation therapy and then gratifying results. Why is the ventricular tachycardia in TOF is so very much amenable for therapy? Because the substrate is very well studied and detecting the substrate is quite easy. We'll have to simply know whether it was an associated with just a ventriculotomy or a patch closure or a patch repair of the TOF. If this is the case, which is most often, then the re-entry is in and around the patch. Whenever you deal with the ventricular tachycardia of a scar, you need to know the re-entry circuit. So we now in TOF know where the patch or a ventriculotomy is there, and it is easy to identify the zone of slow conduction along or around the scar. Typically, more than 95% of the times, the slow zone of conduction is at one of the following 4 places. If this is a patch, the zone of slow conduction is at the isthmus between the patch and the tricuspid annulus, or patch and the pulmonic valve. Like that, either it is the patch or a ventriculotomy. You have just 4 zones of slow conduction if the VT is associated with the TOF. And creating lesions across these slow zones of a conduction almost brings cure to the so-called monomorphic ventricular tachycardia for VT, which is blamed to cause sudden death. One of the ECG features which had been highlighted long time back about the follow-up patient of a TOF. What earlier was assumed that if the patient post-tetralogy of Fallot develops a right bundle branch block of a specific pattern where the PR is longer and most importantly leftward axis, it was presumed earlier that these patients are at a high risk for sudden death because of not ventricular arrhythmia, but because of a sudden occurrence of a complete heart block and long asystole. That was way back in 1972. Even today, the same ECG feature suggests of a poor prognosis, but not necessarily from a bradyarrhythmia point of view. This is simply telling you that there is a scar, the scar which I just spoke about. And this scar is the forerunner of even a malignant ventricular arrhythmia. So we got 2 things clear here. If you have a monomorphic ventricular tachycardia, and if you have a Cues morphology like RBB in the leftward axis with the prolonged PR, and if you are following quite a number of years in your tetralogy of Fallot patient, maybe you should be also looking out are easy developing symptoms of palpitations of a syncope, or you can assess the increase in the chamber sizes, etc. Just to be sure that he is not going to be at risk for sudden death. This slide is trying to demonstrate that it's a regular narrow Cues tachycardia, typically a supraventricular tachycardia, the first thing strikes to our mind is it could be benign. Yes, it is benign as long as the heart is normal. But if this kind of an arrhythmia, which is a common occurrence in the atrial repairs for the TGA, can cause extreme degree of a stress onto the systemic right ventricle, and then this so-called supraventricular tachycardia is indeed a malignant ventricular tachycardia hemodynamically for this patient. It's causing syncopal death. Let me just quickly give some Ecg clues which may tell that the patient is at risk for sudden cardiac death in congenital heart disease. One of the most important determinant of sudden cardiac death in congenital heart disease is the way the QRS looks. One thing I had mentioned, RBP with a left load axis typically in TOF, but in general, if the QRS is wider, telling you there's a hypertrophy or a dilatation of the ventricle, if there's a left bundle branch block, if the QRS is not sharp, but it has got several notches and fractionation, it is telling you that there are the depolarization is not uniform, suggesting the scar of the myocardium. Number and location of the Q waves, loss of the muscle, and also the zones of slow conduction, reduced voltage, dilatation, and loss of muscle. These are the QRS. There are certain more. In a suspected case of a syncope, you may actually look at the signal average ECG, which is simply telling you the delayed depolarization phases, or it is equivalent to the fractionation of the QRS, which tells you there's a scarring. And then if there's an inappropriate QRST angle, is also telling you that there can be a risk for arrhythmia. The ventricular ectopics, like in adults, normal hearts, they also have some degree of benignness, even in congenital heart disease, if they are coming from the outflow tract. That has been seen. As long as the ventricular ectopics do not have the inferior axis, all ventricular ectopies should be looked at with some suspicion. Similarly, very short coupling interval of the PVCs, their frequencies, whether the PVs continue to persist or increase during exercise. If incidentally, if you are seeing episodes of a non-sustained VT, or on a Holter you are recording many non-sustained VT episodes, they all indicate risk. If there are ventricular ectopics and if one time there was a sustained VT, well, you can always be certain that unless that is treated, he remains at risk for sudden cardiac death. With respect to the prevention, well, you can go by drugs. Most often the drugs would be considered empirical. There are no huge data in addressing a specific issue of ventricular arrhythmia, specific type of a congenital heart disease. Beta blockers and amiodarone have been tried to varying degrees of efficacy. One may can add sotalol. One may add procainamide. The acute termination of some of the supraventricular arrhythmias, recent ibutylide has been tried in a limited way, even though it is not recommended. One may try because of its short duration of action. Ablation, I was telling, some of the ventricular tachycardias, typically they are associated with TOF. They are amenable to ablation. Ablation has a role, definitely, even after drugs the patient is symptomatic or you are recording those arrhythmias. Defibrillators seem to be the definitive therapy for the prevention and the treatment of sudden cardiac death, because at that time of a ventricular tachycardia, patient may not be able to reach the hospital and he requires an immediate cardioversion by defibrillation. So defibrillation, especially in a patient who had been resuscitated from sudden cardiac arrest, is a strong indication. And if you think the patient has got ventricular dysfunction, wide QRS, one may actually look at whether it is feasible to narrow down that QRS by cardiac resynchronization therapy, and either by itself or an addition of a defibrillator may take care of these arrhythmias. For the ICD, I mentioned it is definitely indicated in those patients of congenital heart disease who had been resuscitated from the cardiac arrest, and that was due to documented ventricular arrhythmia after the exclusion of the reversible causes. It could also be considered in those patients whom you think they are at the high risk. For example, palpitations, syncope, documented sustained VT. You may consider an ICD straight away, or you may wait for the effect of the drugs, which I told you could be empirical, or you may consider an ICD if there is a recurrence of an arrhythmia after the radiofrequency ablation, or you may consider an ICD even after the radiofrequency ablation, because radiofrequency ablation is also not a guarantee for a permanent cure, or not a guarantee against the presence of an arrhythmia. One may consider an AICD after making an assessment whether you require a percutaneous or a surgical correction of the residual hemodynamics, or the resection of the scar, if possible, to eliminate the VT. What is also important is the defibrillator, especially in the children. It is quite cumbersome because of the size and the leaks, etc. But especially in adults, if you think that to do some percutaneous or surgical correction, be sure that these leads the leads of the defibrillator which are going to be placed should not be hampered or in a sense. For example, the tricuspid wall or the pulmonic wall repair, if it is being considered, it is preferred that those corrections are done and the leads are placed. So the timing and the interventions need to be clear when you are thinking about ICD. Is there a role for an EP study? Well, we discussed so many parameters, hemodynamic parameters, ECG parameters, symptoms, etc. It may not be required to do the EP study. But in unexplained syncopal episodes, in the absence of, for example, Pvcs, no documentation of sustained or non-sustained VT, and then longer term of a follow-up of those patients, if you are thinking that could have been a malignant ventricular arrhythmia, treating blindly without an EP study may not be appropriate. So one has to consider, at least in such situation, an EP study. This is an example of a patient who is at risk for sudden cardiac death, who never had any issues. However, he had one episode of a syncope. You do all those investigations here. Nothing seems to be very abnormal. RBBB typical and the normal axis, etc. But one feature which is telling you that the QRS is about 210 to 220 milliseconds. That is quite wide. If you have documented a progressive QRS widening, typically 40 to 80 milliseconds occurring rapidly over 1 year period of time, is supposedly be telling that either the ventricle is dilated, and if not, the conduction pattern is changing, which simply tells that the scar is building up, which could be the substrate. So a simple ECG, but looking at the symptomatology might actually alert you regarding the possibility of sudden. A quick word about the type of the ICDs, what you consider to improve. For example, this is the data from the follow-up of patients with the TOF. What is interesting, in those patients who had been given defibrillators who were young, for example, less than 15 years, You see this gray zone is for the secondary prevention. Most of them were given defibrillators as a secondary prevention. That means the defibrillator was prescribed only after there was an event of resuscitated arrest. So very few patients tend to have a primary prevention defibrillator. But as the patient grows, and we already discussed that the risk accumulating for sudden death. If you look at the major centers, this is the uniform distribution curve among the patients of top who underwent defibrillator. Majority of them is black bars. Most of the patients who have undergone defibrillator in top patients beyond the age of 16, they have had a defibrillator for a primary prevention because either they had palpitations or a syncope undocumented of a VT, or their hemodynamics, or their ECG characteristics, or their EP characteristics were suggestive of ventricular arrhythmias. And then how about the result of this? If you look at the data of those patients who had undergone a primary prevention, the rate of appropriate ICD shock, which is a surrogate marker of the incidence of sudden deaths. What we notice here that those patients who have had a defibrillator for primary prevention had the maximum benefit if we consider these shocks are appropriate in those patients who have had end diastolic pressures of more than 12 mmHg. That means if you have documented ventricular dysfunction, and if you think there's a risk for a sudden cardiac death in him, you should be considering defibrillator as a primary prevention or a prophylaxis against sudden death, which is not different from those patients with coronary artery disease with ischemic cardiomyopathy. The same principle probably is playing a role here. Congenital heart disease, if you think the ventricular dysfunction is setting in, the patient has congestive heart failure, and if there are additional markers for sudden cardiac death, you can consider defibrillator as a primary prevention. Next to this, the other group which are in the descending order of risk are non-sustained VT, ventricular incision scars, a QRS duration of 180. So this is helping you. This is validating the assumption that these are the patients who are at high risk for sudden cardiac death, and then you should be strongly considering either drugs or ablation or a defibrillator in your patients of congenital heart disease. Clinical presentation is important. If the patient has cardiac arrest due to sustained monomorphic VT, one should consider strongly the ICD. Beyond ICD, if the patient continues to have these VTs, well, one can look for antiarrhythmic drugs, which are empirical, ablation, or try to reduce the shock of a defibrillator by programming anti-tachycardia in the form of a syncope and a sustained palpitations, which will tell you he is at the risk for sudden death. In those patients, if you think the ventricular arrhythmia was a cause, there's no need to blindly prescribe an ICD or an antiarrhythmic drug. Maybe you consider an EP study, because the EP study is going to tell you whether the patient has got indeed a VTVF, or there are certain treatable atrial arrhythmia without the defibrillator in the form of the drugs, which are probably more efficacious with respect to atrial tachycardia. And one can also think about an ablation for this, and hence bringing down the incidence of sudden death. So EP study helps in those patients who have got a syncope or a sustained palpitations without the documentation of monomorphic VT. How about the minor symptoms? Well, you are always cautious, even if the patient has the minor symptoms of palpitations, etc. It may make sense to advise Holter, because it may actually pick up sustained or non-sustained asymptomatic episodes. And if you think there are only PVCs, you may actually risk stratify. How to risk stratify the PVCs? Like in an adult patient, for example, you look at whether they're associated with symptoms, etc. But even in the absence of the symptoms, if you are seeing PVCs frequently, it is necessary that we assess the PVC burden. More than 10,000 over a period of 24 hours? Well, it is usually reflective of an underlying LV dysfunction, or you can consider that it may lead up to the deterioration of LV dysfunction. And in that case, you need to be treating those PVCs. How do you treat the PVCs? Well, empirically you can treat by medically, but as long as the PVCs you think they are not amenable to medical therapy, which is more often, you may consider catheter ablation. Note here, as long as you are not documented the sustained VT, PVCs have never led up to the recommendation for an ICD. So there you can be careful. If you have a PVC, even of a huge burden and an LV dysfunction, expected LV dysfunction, it is not at that stage you should be going in for a defibrillator. The guidelines don't recommend it. Very quickly, going by the 2014 document, I picked it up because this has addressed specifically the ventricular tachyarrhythmias associated with congenital heart disease much better than any one of the guidelines. And indeed, this particular guideline has been endorsed not only the European Heart Rhythm Association, also the electrophysiologist world called Heart Rhythm Society, and our own Asia Pacific Heart Rhythm Society. Indeed, is a globally accepted what does it say? Cardiac arrest. This patient goes for an ICD therapy straight away. Well, if there is still an issue, you can consider an EP study and look at whether you can have an SVT as a trigger for a monomorphic VT, which is very rare. So one can straight away consider an ICD. Who is the other high risk? Syncope and sustained palpitations. In the absence of a documentation of arrhythmia, you please evaluate hemodynamically the patient, find out whether the corrections can be performed. And apart from that or after that, if the patient continues to have sustained palpitation, EP study is mandatory because you may miss out on the risk for sudden death. Some of the intermediate risks, longer the follow-up, older age at which the patient underwent the procedure, and the other hemodynamics which I had discussed, including the ventricular dilatation, increased end diastolic pressures, the QRS features. There are patients whom you think they are living a normal life and their life expectancy normal. They are the low risk. In those patients also, you should be looking at PVCs if they are had, and then if the burden is increasing, because that may be the sign of an underlying LV dysfunction or may add to the ventricular dysfunction. So thank you very much. I, as usual, have enjoyed